Okay, good afternoon, everybody. Just welcome to COVID Conversations, Science Solutions as Success Stories. And it gives me great pleasure to introduce everybody to today's topic, investigating deaths and outbreaks, an underused tool, and applying incident cause analysis methods, a core OH&S principle to identify contributing process and system factors for awareness and prevention. And I'd like to introduce everyone to Mary Jane Vince. She's an investigator trainer with SafetyWise. So Mary Jane Vince, just to provide a bit of background, her experiences in the mining industry in Africa, North and South America. She's worked in a multicultural stakeholder engagement, working with organizations, local communities and the government. Mary Jane joins SafetyWise, which she'll talk about, in 2012 in North America and Botswana, before recently relocating to Canada, providing ICAM training, incident investigation and consulting services for clients in multiple industries. Mary Jane is a graduate member of the South African Institute of Occupational Safety and Health and member of the Canadian Society of Safety Engineers. I just wanted to provide some slides just to frame Mary Jane's talk. And I just want to quickly put this slide up, just a wastewater signal across Ontario. And if you go to the hyperlink, you can look at the different regions. This is just across all of Ontario. And we can see from the wastewater signal, it's on the rise again. So no, folks, the pandemic's not over, unfortunately. And we can see that the water signal's on the rise. So when it comes to COVID-19, which we know is an aerosol transmissible disease, or any other infectious disease, as a matter of fact, it's really important that there's an effective investigation. And the investigation is more than just contract tracing. I just kind of think about, the theory of Heinrich and the publication Industrial Accident Prevention. The old-fashioned thinking was, there's a chain of events that leads to an incident, and there can be an unsafe act that could lead to that. In Heinrich's book, that was. And the idea was to remove the worker, remove this unsafe act. But we now know that that's wrong. It doesn't apply anymore. So errors are seen as consequences rather than causes. So this is all about going upstream, looking at systemic factors and looking at, the system defenses. So when an adverse event occurs, the important issue is not who blundered, but how and why the defenses failed. So really, it's not about blame the worker. And I guess I just want to really reinforce the importance of that point. If we think about, engineers and management system failures, this is just, failures identified in incidents from the Chemical Safety and Hazard Investigation Board. So, this is kind of old science, but it's still very relevant now. Lack of hazard review to predict and prevent incidents, insufficient investigation and follow-up after previous incidents, inadequate training of staff, and failure to implement effective mechanical integrity programs. I just, I really want to refer back to a talk that was provided by Matthew Oliver. It was in December 2021. Matthew's a failure analysis engineer expert. And I think it's really well worth watching this, maybe after this webinar. Have a look at this, and he talks about failure from an engineering perspective. And I think what really stuck out with me when I looked at this again, he talked about normalization of deviance can lead to group think. So normalization of deviance. Does it sound familiar where we are now? I just want to also think about recent outbreaks. Here's a recent outbreak in a long-term care home in Hamilton. And, we kind of asked the question, what kind of investigation was done for this outbreak? Also, this is just an older paper looking at comparing long-term care homes in Ontario versus British Columbia. There's some findings in there. But when I look at this paper, And I did a search. There's no mention of respiratory protection. There's no mention of ventilation, filtration, or using CO2 monitoring. And just something that I just noticed on the media, the Canadian Security Intelligence Service dismissed Gary Voss-Smith for giving an interview to Global News about the lack of mandatory masking at the agency building in Ottawa. And there has been an outbreak there. And so another occupational hygienist from the University of Toronto said there would have been a significant risk reduction if they had masking all along. So you kind of begs to answer the question, what about safety culture leadership? This Matthew Oliver tweeted this recently about an outbreak at the Sangway Lac St. John Integrated University Health and Social Services. Approximately 400 employees had received diagnosis positive for COVID over a period of 2.5 months. More than 70 patients were also infected inside the walls. And so if you have a look at that tweet, one of the CO2 levels that they measured was up to above 1600 ppm. So the WSIB do have a Q&A section about, looking for claims, and they do focus on, they do refer to nurses and ICUs, first responders and personal support workers. There's a lot of really good information from the Institute of Work and Health. Peter Smith talks about at the start of the pandemic, the collection of work information in many jurisdictions was limited to whether someone was a healthcare worker or not. That was largely out of concern about transmission from workers to patients, not worker to worker to community transmission. So really, they've done a lot of work, and they've shown that work is really important source of transmission, exposure transmission. And the workplace outbreaks have constantly been observed across many industries beyond healthcare. And then just with the new findings, they've sort of suggested or indicated that it's consistently high in agriculture, healthcare, and social assistance, food manufacturing, educational services, and transportation and warehousing over 3 time periods examined in our study. It's just a paper about essential workers that's worth looking at, manufacturing workers, and also migrant agricultural workers' deaths. There's a paper there as an issue as well. I just also came across this on the web. It's an article about migrant workers, and just this person is saying he's interviewed, and the sort of caption is, "Please don't tell anyone that I called you, because if they knew that I was the one who is calling the ambulance, I'm going to lose my job, or they are going to call the government, or they can do something against me." So really, whenever there's a critical injury or death, it's important to do a detailed incident investigation, identifying all contributing factors and root cause analysis. This should be applied to occupational illness and disease, which is what we want to focus on today as well. So the incident cause analysis method can determine contributing factors by identifying deficiencies within an organization's system and processes. The focus of the investigation is at an organizational systems level and includes both cultural and behavioral aspects. The methodology can be applied to any major event, such as a gas leak resulting in an explosion or an uncontrolled outbreak of SARS-CoV-2. And I've just provided the hyperlink to the outbreak in the Hamilton Senior Home, the outbreak there. So without further ado, I'll pass you over to just going to get it over to Mary Jane. Thanks for your time, Mary Jane. Much appreciated.
Thank you, Kevin, and thank you very much for the introduction, and obviously for having me here today. Just before we kind of get started in looking at the ICAM process itself, just to, Kevin, you've introduced me, but just to give you a bit of background as to who is SafetyWise. So SafetyWise is an Australian-based company, but we have global presence. We have a dynamic team of around 16 consultants who are subject matter experts in their area of investigation in multiple industries. As a business, we've trained well over 100,000 people, and in 20 years, we've investigated some of the world's most significant workplace incidents. So as you mentioned, Kevin, I'm actually based in British Columbia, Canada, but we have consultants located throughout the Americas, Africa, Europe, and Australia. Just to give a bit of an introduction and some background to ICAM for those who aren't familiar, and Kevin's actually kind of introduced part of this process already and has introduced James Reason and some of his concepts. But the ICAM process evolved from James Reason's well-known Swiss cheese model, his model of accident causation, which has been successfully applied for more than 30 years in the international aviation community. And the process was originally developed within BHP as the organization was looking for one tool or one methodology that they could apply to all their businesses, from petroleum, steel manufacturing, transport and logistics, etc., that allowed for a standardized approach when it came to investigations, essentially looking for a common language throughout their business. And ICAM was developed to meet those needs with the assistance of industry experts and Professor James Reason. The original design intent is obviously it's investigation, it's a reactive tool. So we use it to deconstruct how and why an incident occurred, and then use it to reconstruct how to prevent the incident from happening again. So very much a reactive process, but is being used more and more proactively too as a risk management tool beyond just, a high potential event. We use it for identifying potential unwanted events, and we use it for investigating positive outcomes too. It seems a bit strange to do that, but if we don't look at how we achieve good performance, how do we know we got that result? Because we have the systems and the controls and the processes in place. Was it just luck that got us to this point? Or let's have a look at how we did it, and then we can take those learnings and we can repeat how we're doing things in other areas of our business to ensure that we have continuous improvement. So it is a very flexible tool. It can be applied to other settings beyond the traditional application in aviation. As you've heard, my background is mining, but we use it in transport, manufacturing, medical. And again, it's always been traditionally used as a safety tool, but it shouldn't be looked at purely for safety-related events. It's a problem-solving tool. It's used for continuous improvement. So can and should be applied beyond safety to any unwanted event in any business, in any organization. Within SafetyWise, we've used this process for investigating environmental impacts, production loss, equipment damage, quality control issues, sexual harassment in the workplace, and has been used for addressing occupational diseases like silica, lead exposure, and the reason why we're here today, because we've done some COVID investigations too. The process itself is fairly simple, it's intuitive, and it uses a very structured and logical framework for data gathering, data organizing, and data analysis. And when we do the investigation, we focus on reverse engineering the event. So we start at the incident and we progress backwards in time to identify, firstly, what defenses or controls do we need in place to prevent the hazard causing harm, or at a bare minimum, to minimize the harm from it. Secondly, what are the actions of the individuals involved that we need to promote or prevent? And I'll come back to this concept later because, as Kevin has mentioned, we need to go beyond just the human factors and the human error to really understand why an incident occurred. Third, we look at the conditions, both task and environmental, that influence behavior and risk. And then lastly, we look right into the past at what we term organizational factors, like root causes, that we need in place, firstly to ensure resilience and resistance to incidents. So through the analysis of all of this information, ICAM provides the ability to identify what really went wrong and to make recommendations for remedial action to reduce risk and build error-tolerant defenses against future incidents. I want to just go back to one of the, I'll call it a podcast, but one of these discussions that I watched a couple of weeks back, which was hosted with Raina McIntyre. And Raina had stated in part of her discussion that there had been studies in teaching about analyzing the origins of epidemics. She spoke about teaching methodologies using case studies, but also stated that investigations into epidemics needs to be thought of in the same way as a homicide investigation, that there are lots and lots of different lines of evidence that need to be reviewed and understood, that timelines need to be developed so that we understand the logical sequence and how latent conditions relate to the incident, what was going on in the past that's related to what's happened at the present, and that there are usually simultaneous events going on. And Raina stated that these kinds of formalized investigations haven't really been done. She further stated that we can't answer the question by simply looking at the genome. We have to look at multiple contributing factors. And ICAM allows for this. It allows for the identification of multiple contributing factors to the event, and it presents them in a very structured and logical way. So off the back of this, I'm certainly not stating that occupational diseases are not being investigated in the workplace, but would argue that many of these don't take a very formalized approach. And we see that in multiple industries that we work in. It's kind of like we wing it. We're doing the best we can with the information that we have over years of working in a particular industry. But it's exceptionally important to have a standardized approach because it's tried and tested and we can compare our findings, which is obviously crucial when we look at outbreaks across a province, across an organization, even across the country. We want to be able to compare our findings and learn and piggyback off what others are doing. But how do we check whether we got the desired outcomes? How do we get repeatability if we're all using different approaches? How do we audit to ensure that we have the right outcomes, that we have confidence in what we've done? So as investigators, we want to be able to demonstrate all of our evidence to show that we've done our due diligence, that we have the sequence of events, we understand how conditions and actions link together, that we've analyzed all of this data to determine those underlying causes and latent conditions. We're all human, we all make mistakes, we're all fallible. So if we follow a tried and established process like ICAM, we reduce the likelihood of error and we increase confidence in the outcomes. Furthermore, we can track and analyze trends. So I want to bring up a quick slide. I hope that we can see that. You should be seeing a slide showing the Swiss cheese respiratory virus pandemic defense. And
the slide's good. Thanks.
Thanks, Kevin. And sorry, I just got a bit lost there. So you've probably seen something very similar to this. There are very similar versions to this model floating around all over the internet over the past couple of years. And as we've heard earlier from Kevin, the Swiss cheese model, it's not new. It's really a simple barrier approach to an investigation, where each of these layers of cheese, as you see on the screen, represents a barrier or a control. And all of these layers have strengths and weaknesses. And the idea behind this is that the more layers we have in place, the less likelihood that an error, represented by the red arrow on the screen, can make it through all of those layers, resulting in an adverse outcome. So the ICAM process identifies the flaws within those barriers or those slices of cheese and makes recommendations to reduce risk and prevent recurrence. And really the concept here is that we're not looking for a one fix all to an event. Incidents don't happen because one thing went wrong, but we're looking at multiple controls to ensure redundancy within the system. So if we think from a COVID perspective, as is demonstrated on the screen here, we don't just focus on vaccines or mask wearing or hand washing. It's not just one or the other. PPE, for example, will provide interim solutions in a planned program to eliminate or reduce risk. Each control may not be sufficient or perfect on its own to produce the desired result, which is elimination of risk, but together they can close off the gaps. So this diagram is a very basic representation of the contributing factors to an incident. What we do at SafetyWise is we take this one step further with the ICAM model is we take all of these contributing factors and we organize them into an ICAM framework to understand how they contributed to the incident. And we do that by categorizing them into 4 columns on an ICAM chart. And the first column of that chart are the absent and failed defenses. I'll just get my laser here. So we're looking at this first column. So as I mentioned previously, when we do our investigation, we start at the incident and we work backwards in time. We identify the absent failed defenses or controls. We then look at the active failures and latent conditions. So what you see on the screen is an overview of what you could expect to find as contributing factors for any COVID-related event or outbreak. So I haven't been specific here, I've just taken a generic example, just to show you how the information that we've seen in the previous slide on those slices of cheese is categorized and organized on this ICAM framework to fully explain how those contributing factors contributed to the event. So when we talk about defenses, we're talking generally about engineering or procedural controls that were in place but were ineffective in managing the risk. So we would refer to those as failed defenses. Or we look at the absent defenses, those defenses that should have been in place. They are a reasonable expectation of what should be in place for our industry, for the organization, for the risk or the hazard that's being looked at. And these are generally our last lines of defense. So if we look at generic examples beyond COVID, we're looking at things like interlocks, isolations, guards, barriers, risk assessments, safe work procedures, supervision, emergency response, PPE. But you can see I've put a couple of examples on the screen there to demonstrate those COVID controls. Once we've identified what those controls were, we then go and work towards the individual team actions. And so here we're identifying the actions of the people directly involved that had a direct impact or a bearing on the outcome of the event. So these are generally the actions of the people physically doing the work, your operators and maintenance personnel. And if we look at a long-term care home, it's your frontline workers. So this describes very specifically who did what or who failed to do something that had a direct bearing on the event. The next column looks at the task and environmental conditions. So these are the conditions that were present at the time or immediately prior to the incident that influenced individual or equipment performance. So by capturing the conditions, we're ensuring that we put the human error in context. Really what we're saying is people did certain things. Why? Because of certain conditions that were influencing their behavior. And then finally, we look at organizational factors. A term you would have heard in the past would be root causes. And these are the decisions by your managers, designers, engineers, and when we look at COVID, regulators, public health, the federal government, that allow or promote certain conditions to exist. They are typically the underlying reasons for why the other contributing factors exist in these other columns. So really, what I'd like to demonstrate now is that unlike the slide we saw with the Swiss cheese model, there is a causal relationship between each of these columns. And this shows us how this framework puts the human error in context. By doing this, we demonstrate the importance of focusing on the organizational factors, the root causes, as these set the scene and create the conditions that influence how we work and the decisions that we make. People do not operate in a vacuum. We are influenced by everything that's going on around us. So I've just highlighted on the screen that one particular type of control is the use of masks. And in certain settings, surgical masks may be ineffective in reducing exposure or spread. The action may be that employees don't wear them consistently or they don't wear them correctly. So now we see the action that is undermining the effectiveness of the defense. we've all seen this over the 3 years that we've been dealing with COVID, is people either don't consistently wear masks, or you find people wearing a mask on their chin or below their nose, or they, take them off regularly. They only put them on when, they're being supervised or someone's checking in on them. When we look at the conditions, the reasons why people don't wear the masks could be related to conflicting messaging about the effectiveness of masks. Right? What type of mask do I wear? What's effective? What's not effective? What are the changes? Do I wear a cloth mask? Do I wear a material mask? Do I wear a surgical mask, an N95? And another reason that could be influencing consistency in use is the fit, as well as the fact that most people feel that it restricts breathing over a long period of time. When we look at the underlying causes, the organizational factors, we may identify that the reason why there is conflicting messaging is because from an organization perspective, let's say public health or the company that we work for, there is a lack of standardization in the communication. There may also be a lack of available resources. We just have to think early on in the pandemic when there weren't enough masks or there wasn't enough hand sanitizer. So the resources we have available, the quantity, the type, is going to influence how and what we use, which then obviously undermines the effectiveness of the defense in the first place. Very quickly, a last example. Social or physical distancing would be considered a control. Workers, however, choose to go back to work and are working in confined, close contact settings. Well, why? Because there is pressure to work to support their family. Why is this the case? Because early on in the pandemic, maybe we didn't see that employee benefit programs were in place and were addressing the needs of the workforce. Things like not providing adequate leave days to get better once you had presented with COVID symptoms. So we're just trying to demonstrate that this process is based on systems thinking. To achieve significant and sustainable improvement in workplace safety, every accident or every incident needs to be considered as a failure of the system. It's not just a failure of the individual, even though human error or violations may be involved. So very quickly to stress, though, that this does not absolve individuals of personal accountability or responsibility, but the process works through going back to the organization or the system failures, and if performance management is required, then we apply fair and just culture from that point. So I wanted to bring up a specific example of an occupational hygiene incident, obviously, to demonstrate the steps that are followed when you conduct an ICAM investigation. And I've used a COVID-related outbreak at a workplace here in Canada that I had investigated actually fairly early on in the pandemic. So from an ICAM perspective, when we do an investigation, we follow a 7-step incident management standard, and is probably not very different in terms of the broad steps to many other investigation processes. But the framework and the templates that we use are obviously different, and at step 5, we are using the ICAM analysis to analyze all of that data. And these steps should be followed in every investigation, but they need to be tailored depending on the nature and the complexity and the type of event that's being investigated, and they need to be scaled. Okay. And as we work through these 7 steps, we're really asking and answering 4 key questions, which should be asked and answered during any investigation, whether it's a occupational hygiene related, or whether it's safety, or whether it's equipment damage or production loss. What happened? Why did it happen? What are we going to do about it? And lastly, what did we learn that we can share with others? And I think that's often where we don't do a good job of communicating those findings so that we can be proactive. Others can learn from our mistakes. The first step of the process, the immediate actions, is what would occur at the workplace immediately after identifying that there has been infection or that there is a outbreak emerging. You know, what do? We stop work, we test people, we provide medical treatment if required, we quarantine or isolate certain people, we start contact tracing, we communicate to the public, the health, the regulators. You know, your first couple of steps are going to be fairly specific depending on what you're dealing with. And typically that's beyond the scope of the investigation team, because that would have been done, hopefully, immediately post-incident. We would need to look at how this was addressed. What were those immediate actions? How did we do our contact tracing? Was it effective? Did we have enough people doing it? Was it going far enough back in time? What type of testing was done? Was it done to the required standard? Did we communicate adequately, etc.? So that still becomes part of your investigation. You're then going to plan your investigation. And out of everything that I've listed here on the screen, I think from a COVID perspective, really important is understanding who needs to be part of this investigation. I think what we've seen, and I don't want to talk out of turn, but I think what we've seen is quite a lot of silo mentality, where you have smaller bodies or individuals doing investigations, possibly on the same area, but we should be doing them together, right? We should bring in all the subject matter experts and do one full investigation where we identify all those multiple contributing factors. It's in one place, it's easy to reference, and it's easy to share. Once we've planned our investigation, we then actually start on doing the investigation. So at this point, we would have a team of experts together and we would start on some data gathering. And from an ICAM perspective, we use 5 key data categories, and we refer to this as PIPO. So we focus on the people involved, the environment, the equipment, the procedures, and the organization. And when you're starting that PIPO Mark 1, it's a brainstorming exercise. The idea is to brainstorm sufficiently broad and treat every possible contributing factor as a possible data source. So we would start with a group sitting around a wall in a room or a big whiteboard, and we would start brainstorming what type of data do we need to gather? What are our data sources? What questions do we have? Who do we want to interview? What was the environment where this took place? What equipment were we using? What should we have been using? How was it used? Was it maintained to the required standard? What procedures, policies, and standards do we have around this location? The individuals doing the work, the risk. And lastly, we look at the organization, which is where we address things like scheduling, planning, and incentivizing of work, operational pressures, the overall management and supervision of work in whatever environment you're looking at. So again, the important concept here, as I've mentioned earlier, is that we're focusing beyond human error to identify and understand the multiple possible contributing factors. And by using this type of a framework, it encourages the investigator to go beyond just who did what, and to really investigate all of those key areas, all of your sources of data or evidence. Once you have all of this data, you're then going to go out and gather it. So you use this chart almost like a checklist to keep you focused, to ensure that you don't forget any of the pertinent information that you're looking for. It ensures that you ask all the questions and you fill in the gaps. And when you come back with all of that information, you add it back into what we now term a PIPO Mark II. And this is all the evidence that you have gathered and summarized. For example, we have one employee who is 66 years old, is a non-smoker, is a type 2 diabetic, and is on a current established treatment regime. It tells us about who was involved. And you would continue through all the people involved, and you would identify actions, training, experience, awareness, etc. We also look at the environment, and for example, we identified that all non-essential travel to and from the workplace was delayed right at the start of the outbreak. We identify in the organization column that the pandemic plan that they had in place did not adequately address all COVID risk factors. So I want to highlight here that this incident occurred in early 2021. So don't focus too much on the detail because, you know, this was evolving and some of the detail has probably changed and some of the legislation and what we know about COVID has probably evolved since this point. But this investigation was done on the available information at the time. And so I want to again stress that we're looking at all the data. Once you have that data, you are then going to identify which of this evidence is considered contributing to your event. And we've highlighted the contributing factors in yellow. And it's really important to have all of that data because it shows you've done your due diligence. We haven't made an early assumption about what we think is important. We've looked at all the evidence, we've summarized it, and then we've looked at, okay, from this evidence, which of these are considered contributing to my event? Once you're confident that you have all of that data, the next step then is to organize this data into a timeline. And this enables us to present a logical sequence of events. I like to think of this like a book. You took a book and you ripped out all the pages and you threw it up in the air. When you collect all the pages back together, you can still put them into a book, but they're not going to be in the logical order. You still have all the information, but it's not sequential. It doesn't make sense in the way that it's presented. And that's what your PIPO Mark II is. It's your book with all your pages. And what you're doing in step 4 in your timeline is you're now organizing all of that data to understand the critical decision and action points, and you're establishing the link between your latent conditions and the incident. It's a really great way to identify conflicting or missing information. And you know, timelines, I guess, are developed quite regularly when we talk about COVID, because when we look at contact tracing, we're going back in time and looking at where people were, what were they doing, who were they interacting with. So this is all logical to present on any timeline related to your event. So here's an example of the timeline for the incident that we had investigated. And you can see that we've gone as far back as March 11, 2020, when the pandemic was declared by the World Health Organization. And then we have literally put key events and actions along that timeline over a period of a couple of months, all the way until we had that first fatal event. So I don't want to focus too much on the detail that I've had here, but just demonstrating again the importance of understanding how your incident developed. What were the conditions, the actions, the environment that led to this outcome, so that you have it organized and sequential.
It's a webcast, very interesting.
Sorry.
Can you mute yourselves, please, if you're not muted? Thank you.
Once you've completed your timeline, at this point, we should have a very good understanding of not only what happened, where it happened, who was involved, but we might already start to understand some of the reasons why it's happened. So this leads us into the next step, which is analyzing all of this data that we had. So you go back to your PIPO Mark II, where you have all that detail, all that summarized evidence, and you look at those contributing factors, and we're going to build a contributing factor pathway that identifies latent conditions, active failures, and absent failed defenses. And all this is, it sounds overly complex, but it is a very simple process. It's a transfer of data from your PIPO chart through to your ICAM analysis. You're taking your contributing factors from one chart and you are allocating them into one of those 4 categories on your ICAM chart to determine how they contributed. Is the contributing factor considered a defense? Is it an action of an individual? Is it a condition that influenced behavior? Or is it an organizational factor, a decision made in the past by the organization, regulators, designers, engineers? So there is a lot of detail on this chart, but I wanted to present a full overview of the amount of detail and the context that you get when you follow a very formalized structure in investigation like ICAM. Just to highlight some of this detail, I'm just going to bring up a couple of them. So in this particular incident that we investigated, we identified that there were no staggered shifts, no cohorts, and no bubbles. So in a workplace where you have 400 people working together, it makes contact tracing obviously very difficult, but it also obviously means from a prevention standpoint, you've got multiple people interacting with each other. So you have, a lack of control over that situation. It's coded as an awareness work instructional procedure, and I'll speak about the codes in a couple of minutes. We also identified that PCR tests for outbound flights were conducted 3 days prior to leaving the site. So for 3 days, you have the possibility that someone starts to present with COVID symptoms, but it goes undetected. And then they're permitted to get on a flight and leave the site, potentially infecting other people aboard that flight. Masks were not required after a 5-day follow-up test result. So you only had to wear masks for a certain period of time and then not from that point onwards. So we've coded these with defense codes, and these are all included in the materials that we provide in our training. And I'll talk about the codes in a couple of minutes. When we look at the actions of individuals or teams, we've identified that it was obvious at the workplace that personnel were not complying to the COVID protocols, both company protocol, public health protocol, and it wasn't just at the workplace. There was a history of non-compliance outside of the workplace too. We had identified that en route to the workplace, employee and a number of people had shared taxis with unknown persons, and it was not disclosed and it was unclear whether or not any PPE or any controls were in place around that. So just an example of demonstrating the actions of individuals that can trigger an event. In terms of conditions, this was an evolving virus. There was ever-changing information regarding strains, regarding transmission and mitigation. And at times, it was contradictory. You had different organizations, different bodies presenting different papers, bringing up different information. You had a lot of information overload. Somebody has referred to it as the infodemic, I think, where it was just a bombardment of so much information, and a lot of it anecdotal, not always evidence-based. So that definitely influences how we respond. The location of this workplace, the geographical location being a remote site, it happened at a time when the weather conditions were less than favorable. It was winter, it was very cold out, so it encourages the likelihood of close contact settings, crowded areas, and closed settings, obviously where the virus is easier able to spread. And we also look at the physical capabilities of individuals. So of the people who were involved in this, 2 of those individuals, unfortunately both deceased individuals, were over 60 years of age. One was a type 2 diabetic, the other had a BMI over 40, so there was some comorbidities, and they hadn't adequately been addressed in the workplace as identifying these people as high-risk individuals. And if we look at organizational factors, one of them was the organization made a decision to not implement PCR testing based on cost and the current controls that they had in place that appeared to be working. Another organizational factor was that during the time that pandemic was occurring and early on, there was no review of the HVAC systems and their ventilation protocols. There was the use of MERV 8 filters in some areas, but other areas hadn't been adequately risk assessed, and there were a lot of other buildings that didn't have adequate ventilation protocols in place. There were this particular organization had a lot of good protocols in place. We identified a lot of stuff that they were doing that was appropriate, doing the best they can with what's available. But unfortunately, many of these controls were administrative, and there wasn't obvious auditing and compliance monitoring to ensure that those were actually being applied and used consistently in the workforce. So this just gives kind of an overview of what we're looking at from an investigation perspective, identifying these contributing factors and categorizing them into these columns. Now, I had mentioned the coding, which is an important part of ICAM. We code our contributing factors firstly because it standardizes your findings. The way I write a certain contributing factor, the way I capture it, could be very different to the way Kevin would write it and capture it, even though we're talking about the same thing and the idea is the same. So by using these standardized codes that we've developed, it allows for standardization through the business. But what's even more important is that it allows us to do trend analysis. We can go back over a certain period of time and we can identify how many times we've had risk management control failures. And we can see emerging trends. We can see hotspots within our business. So this can become almost a proactive risk management tool, because if you can identify trends in one area, you can look to see if you have those trends emerging in others. And you can piggyback off what's being done in one area to prevent similar outcomes in another. Once we've identified all of our contributing factors, we're then ready to develop recommendations, because at this point we understand what happened, when it happened, where it happened, how it happened, and most importantly, why it happened. So now we're going to look at addressing that to reduce risk and prevent recurrence. So we highlight these two outside columns because this is where we develop our recommendations. These are the areas that we as a business have control over. So all of our recommendations are going to address every organizational factor and every absent failed defense. And because there is a causal relationship between these columns, if we address the organizational factors, we usually are by default addressing the items in the other columns. And that's the final step in this process, is to develop those recommendations using the SMARTER principle and the hierarchy of controls, and then reporting on our findings. And as I mentioned earlier this morning, this is sometimes where we don't put enough focus and enough emphasis. And this would be really key in COVID outbreaks, because if we can identify what went wrong, why it went wrong, and put controls in place to prevent it happening again, we can share those findings with other areas of our business, with other businesses in our organization, with other organizations in our industry, in our public health areas, and within the country, and I guess globally too. It's all about scaling those learnings. So just to end off, the benefit here is that by using a process like ICAM, we can provide a consistent approach to those investigations. It provides a roadmap, which means that we can get repeatable results. It provides tools for learning the right lessons, not just somebody didn't do what they were supposed to do. We're able to identify those error-tolerant improvement opportunities, and we can provide usable data for trend analysis. Kevin, any questions?
Thank you so much for that. That was very informative, and just the structure and the framework that's allowed by ICAM really, it lends itself to a great tool. I see that Trevor Fish and Lisa Bross who have questions. There might be other questions coming up in the chat box, but I just want to ask you a couple of questions myself first before we go there. I have experience with doing hazard and operability studies, and I won't go into that, but it's a way of figuring out what can go wrong and what needs to be done to stop, things going wrong again, generally in processing plants and that. And, it's a big sell to try and get the right people engaged in doing that. So I'm just thinking, and I'm just using the long-term care outbreak that I talked about. There'd been 2 outbreaks in the same long-term care home. So if there was an incident investigation on that outbreak, there's a lot of people that infected. Firstly, who should be involved? like who should be involved in an investigation and how much time would that take? Like, I'm just thinking about the resources that you'd allocate for that. That's the first question.
Okay, so great question, because it's a question we get in training all the time. How do we allocate our resources appropriately to get benefit? Understanding that resources are not infinite. They are finite, and we have to use what we've got as best we can. The idea, if we're talking from a best practice perspective, the idea is to have a subject matter expert who is preferably somebody who's not part of that organization. So if we had an outbreak in a long-term care facility, we would want to bring somebody from outside of that care facility to be kind of a subject matter expert and or an expert in investigation. And then we would want to ensure that we have a couple of people from that facility who manage that facility to be part of the investigation team. Typically, when we're looking at high-level events, we have anywhere from 4 to 8 members as part of that investigation team. So it is a little bit resource intensive, but at least by having everybody together, we can work through the investigation as a group, ensuring that we cover on all relevant and appropriate information versus getting to the end and then having to go out and find an additional person to have a discussion with because we haven't fully understood some aspect of that event.
Okay, thanks. And I just guess what prompted that question as well, when you were talking about masking, you were talking about a surgical mask for an airborne transmissible disease. And the first thing I thought about was, why not talk about a respirator? And, that's because I'm a hygienist. I understand the language. I understand that the respirator should be used for exposure to an inhalable particulate matter. So yeah, having the right mix and having occupational hygienists and engineers and other people on the team is so important, especially when we're thinking about ventilation, for example. The other question, it's kind of, sorry, go on.
I was just going to say, a good example of this is I'm certainly not an expert in occupational hygiene and in, COVID outbreaks and the likes, but I would certainly say I'm an expert in ICAM. So I could come and do an investigation with a team. I'm the subject matter expert in investigation, but I would need to bring in those additional key individuals to ensure that I get relevant, accurate, usable data.
Great, thanks for that. The second one, it's kind of a bit tricky, and I'll go there anyway. It's got to do with the recent issue with regards to CSIS that I talked about. So the person that actually said that they needed mandatory masking, and he actually was interviewed by the media, and he lost his job as a result. And then you can ask the question, well, why would he lose his job? And if he's asking for mandatory masking and thinking about organizational factors, the messaging from public health is that masks are no longer mandatory. So, could ICAM be used to feed back up to the government, to public health, to alert them to some of the deficiencies and some of the messaging that's going down?
Absolutely, because when we talk about those organizational factors, those underlying root causes to the events, I use the term organization, but when you do an investigation, there can be multiple organizations involved, like public health, like the company that we work for. So when we identify those organizational factors, there may be some that we as a company have little control over. But we need to be able to identify, if we don't have control over that, who's the next line who does have control on that. And if there are failures in that, we need to be able to communicate those findings back to them. So this approach allows you to show that it's not anecdotal. There is evidence to support that communication has been ineffective, for example, and these are the key data sources that we have to support that. And we would try to feed that up to the regulator or public health to say, look, these are issues we've identified. We'd like you to consider addressing these for industry best practice going forward.
Thanks, Mary Jane. Now, what I might do is I might work systematically through the questions in the chat area here. And it's great to see Dr. Lisa Brosu has joined us. And Lisa's asking, what about asking if the organization has performed a preliminary risk assessment?
Yes, so the risk assessment would be captured as part of your data gathering, and that would be will be covered in either the organizational factors and or the absent failed defenses. So have we done a risk assessment? Was it appropriate? Did it identify all the risks? If not, why? Is there a history? For example, what we see often in, for example, the mining industry is that we have had hazards reported over a period of time, but they haven't been addressed, or they haven't been addressed appropriately by the organization. Those would be considered risk management issues from an organizational perspective. So the process would help you to identify that. If we look at the controls on the other end of that chart, we would look at those risk management tools that we use in the field. So you've got your operational and enterprise risk management, but then on a day-to-day basis, we've got things like job hazard analysis, HAZOPs, take fives, take twos, which the expectation is we've done a risk assessment and we've identified key risks, but we expect that our employees on a day-to-day basis are doing a 5-minute take five before the shift to check if the conditions have changed. Are there issues with equipment? Is there issues with personnel? And then how do we address those before we start our work?
Thanks, Mary Jane. So, I mean, I think just from a process perspective, you know, as you answer questions for the different people asking the questions, if the people want a bit more information and they want to, you know, expand on the question, please put your hands up. So hopefully that answers a good question, Lisa.
And I just want to interrupt you and just go back to a concept here. Incident investigation is basically risk management in reverse. Because when you have an incident, we have obviously failed to be proactive and manage a risk. And the investigation process then allows us to identify where we initially failed to identify and manage the risk. And now we have an opportunity to put controls in place to manage that risk going forward. So there's a very close relationship between investigations and risk management. And coming back to the question, risk management always comes up. I'd say on 90% of investigations, we look at issues with the risk management from an organization and from an individual level.
Great. You know, when you were presenting, I was thinking about how you code the different items. And the first thing I thought about, you know, was the Canadian standard for respiratory protection and ASHRAE 62.1. You know, there's certain standards that we could include in the coding system. So the next question is from Trevor Fish. How do you go about interviewing affected workers?
All right. So if we've had a long-term an outbreak at a long-term care facility, obviously as part of that PEPO Mark 1, that brainstorming, we have that people column, and in there we would identify key people to talk to. So that would be probably you know, people who manage the facilities, some of your frontline workers, but you may also want to talk to people within the public. So you would make a list of key individuals that you want to talk to, and there would be, again, depending on the industry and the setting, there would be clear parameters about how you go about doing your interviews, whether they face-to-face, whether they virtually, and there would be representation there if required. I'm not sure that fully answers the question. It's such a broad question. I don't know if we want to be a bit more specific about how we do that.
Did you want to share your thinking there, Trevor? Or has that answered your question? Okay, please show yourself and ask the question in person if you want. And just, I'm just kind of flipping down to just another. It says, I may have missed whether you mentioned including workers in the ICAM process, or at what point their voice and experience are captured.
Okay, also a great question. So when we put together our ICAM team, we're going to look at getting as broad a representation as possible. So if I I'll go to what I know, for example, mining. If we had an incident in mining, we would look at bringing in someone from the area who does the same work but wasn't on the same shift or with the same crew involved in that incident. So that we have those subject matter experts, right? We have someone who does the work, but they weren't part of that event. We would bring in an individual who is in a supervisory role, but isn't that person's direct supervisor. So a supervisor from a cross shift, so that we could interview them and discuss not only what the expectations are, but how is work actually done versus what the intention is. We would work through to bring someone in from management. We would go possibly to a union if there were, if the organization is unionized, we would bring in someone from the union. So you bring in a multidisciplinary team so that you get representation from different areas of your organization, but also from different levels within that organization. So you do have the workforce giving their contribution, but you also get that management perspective and everything in between.
Great, thanks. So I see Matthew Oliver has asked a similar question about, who do you involve in the PIPO group? Is this any supervisors, or do you include frontline workers familiar with job environment involved? I kind of think that's similar. And I also just wanted to think about, say the organization doesn't have specialists, the organization doesn't have occupational hygienists or ventilation engineers.
Yeah.
Then what would you do then?
So as part of that step 2 in the 7-step process, that step 2 was planning, and the question there was who needs to be involved. This is the opportunity that we have to say, right, who do we have within our business who are subject matter experts, and do we need to bring people from outside? And at that point, we would need to get in contact with those relevant persons and either ask them to be part of the investigation completely or bring them in at certain points to assist and guide us as needed.
Right. And I see sort of Vicky's got to everyone, each long-term care home in Ontario must have on-site IPAC coordinator, funding provided by the Ontario government. I'm just going to throw that out to everybody, what their thoughts are with what Vicky just said there, an IPAC coordinator. Anybody want to share their thoughts there? Okay, I just share mine then because I was sort of fishing. I'm just wondering if the IPAC coordinator would engage with an engineer or an occupational hygienist to help the process move forward with the ICAM process. Would that be the case, Vicky? Would that happen? Please speak up if you can. We're trying to share things. Okay. Okay then.
Hello, it's Vicky.
Hi, Vicky.
Hi, yeah, the IPAC coordinators in long-term care homes, it's a requirement under the Long-Term Care Home Act, and they are occupational nurses. They have expertise in infection control. They have to be certified in infection control through a designation through Queen's University, is one of the major universities today that offer that. They do pick up on occupational hygiene, etc. They do engage in their environmental professionals that are in these long-term care homes, or they have access to them, but they have a dual reporting, and it's to the Public Health, Ministry of Health, and to the administrator of the home. So they have strict controls in place, which is mandated under the Long-Term Care Home Act. I do external audits for compliance. My firm does, to make sure that they're following, and we engage the safety committees. They're all unionized. I don't know a long-term care home in Ontario that is not unionized, so they're pretty sophisticated. And with all the rigors and the iron ringing that we put around these homes, we still are in outbreak status.
So
They
if
do
I can
testing every day.
Thanks, Vicky. That's great that there's that
Okay.
structure in place. Then if I could just follow up with that comment, would the IPAC coordinator look at the Canadian standard for respiratory protective equipment, 94.4, to make sure that's in place? And also, would they make sure that the ventilation complies with ASHRAE 62.1?
They follow the guidelines that are directed by the IPAC certification and the current Ontario Ministry of Health regulations.
And
So
does that include that standard, those both ASHRAE and the respiratory protection standards?
I can't comment on that. We just do external auditing for compliance with regards to, are they ensuring the testing? They do testing every day at every shift. They do swabbing. They still are PP'd up. The vaccinations are there. They put all the controls in place. The government has just released new monies for improvements in HVAC because a lot of these homes didn't have those systems in place. And this is all post-pandemic. Monies that are being transferred to these homes. All the new homes are going to be built with more improved and modernized HVAC, etc. So there's a lot of lessons learned in long-term care. We always refer to long-term care as the second cousins of hospitals, unfortunately, and they don't have the internal structures. Like these standalone not-for-profits do not have these huge conglomerate structures, so they rely on external contractors and vendors to supply services.
And then, so just this process that we're hearing about ICAM, the investigation framework under ICAM, do you think that would be valuable for IPAC coordinators to roll out in long-term care homes?
For what? Sorry, sir?
So what we're hearing today about using this tool, this methodology, do you see value in using this for long-term care home outbreaks?
They have, again, with the certification in IPAC, they have their own tools, and there's tools that are very descriptive under public health IPAC systems, and they probably parallel a little bit because, again, risk assessments and risk controls are pretty much using the same ideology. I've invited my clients I've invited their IPAC coordinators to this session, so I'm hoping that a few of them have attended. And it's, if not, I'm going to be sharing this information with them, but I don't know if they are using it. They have standardized tools in long-term care that they use for assessing risk at every shift. So there's 3 shifts in a day. There's an assessment done at every shift. And sometimes in the middle of a shift where they'll do random sampling to assess infections.
Thank you so much for speaking out, Vicky, and sharing your thoughts with us. Really appreciate that. Now, I just noticed, I think it might have come from Val. Sorry, Mary Jane, you were
I just want to just make one comment on the back of what Vicky was saying there, and I'm not sure if I've misinterpreted, but there's the comment that we're doing a lot and we're still getting outbreaks. We have a lot of controls in place, but we're still having these outbreaks in a lot of our care homes. And I guess we have to accept, and a lot of safety professionals and the likes of you guys, we accept that sometimes we cannot eliminate the risk completely, but we at least need to do what we can with what we've got, with what's available to industry best practice to reduce the risk to as low as reasonably practicable. And I guess that's what we're trying to do here. We accept that in some cases we cannot eliminate, but we can do what we can to reduce the level of harm when those events do occur.
And if I could respond to that, I agree with you, because number one, COVID is not the first outbreak. Like we have enteric outbreaks, we have influenza A and B outbreaks right now in Ontario, which is standard. So these homes know how to manage outbreaks, and they know how to control these outbreaks. And there is a level of a risk in all of these environments. The measurement is death rates and the length that they're in outbreaks. So we're seeing outbreak times reducing, which that's a good sign. And we're seeing death rates in long-term care reducing, and we're seeing a reduction, God forbid, our workers' numbers reducing in this sector, because there was a death rate there also. So those are the outcome measures, but they do those measures even with influenza A and B and enteric outbreaks, just traditionally measuring, you know, lengths of time the outbreak is there and what controls are put into place. I'm just very pleased as an outcome of the Long-Term Care Home Commission, nothing to do with COVID. They came to the conclusion that infection control was important and that the government was going to start funding those positions in all these homes. So that's one of the positive outcomes, I guess, that we can, you know, congratulate COVID with. At least it's a good start. They have some credentialism around it. These individuals are working at it, and they're just doing their best right now. And they are engaging the unions and the health and safety committees as a best practice. But yeah, the measurements, we're seeing significant reductions now. But they're still under control, right? Like everybody gets screened every day, they're PPD'd up, they cohort, etc. So they're still pretty tight in these environments and in our congregate living environments, such as our shelters and group homes. So we're getting there. We're beside COVID. It's not ahead of us. It's not behind us. We're walking beside it. That's how I put it. Anyways.
So thanks so much, Vicky. I'm now going to flip back to this comment here. I think it's probably from Val. It's kind of wondering if folks in the audience have participated in any occupational infectious disease investigations, and what was the outcome? Were prevention strategies identified, and most importantly, communicated and then implemented? So I guess we have 54 people on here, and I'm just wondering if somebody would be brave enough to share their what they've done with the team here. We're trying to learn from each other here. So if you feel brave enough to share your situation, that would be great.
I had the same question actually for Mary Jane. So you showed us an example of where you had the opportunity. To me, it's an opportunity to be able to go in and spend this much time to investigate, to figure out what went wrong, to potentially improve the situation. I guess we don't know where it is, but I guess more in general, how often or what's the success rate, I guess, in making change, that the investigation influences a change that is indeed protective and preventive? And if there's any follow-up strategies, I guess, any advice around that?
Yeah, I think, Val, it often relies on the maturity of the organization that you're looking at. You know, if the one positive is if we get asked to do an investigation, you know, that's great that they've recognized that something has occurred that requires more than just a quick and dirty investigation at an operational level, but to bring a team in and actually focus on that. So we would come up with a key set of recommendations for corrective action coming off of that ICAM chart. So things like, you know, improvements to pandemic response plans with specific key details that should be added to those plans based on the failures that were identified from the investigation. What we sometimes find is a bit of pushback from organizations to implement the changes, which is, it's saddening because we've gone through all this effort. We've not only hurt people, we've taken a lot of time away from people's lives because we've had to shut down operations. It's cost a lot of money. It's impacted families. Then you bring people in to do an investigation that costs a lot of money, and we come out with a key set of corrective actions. And then the stance is, well, we're not going to do this because we think that that's going to cost us too much money. Or in this case, it's, well, we're not going to implement those controls because it's behind us. We've had the outbreak, it's done, so we're good now. We don't need to implement these controls. So we're not being proactive with the data. And unfortunately, we have, you know, when I'd say we, safety-wise, has little control over what the organization does with those findings afterwards. Ideally, they should be looking at those from a business level and saying, okay, let's prioritize some of these. There are, you know, this has come from an investigation, not just with an external person, but it was done with the collection of our people from our organization. So there is merit behind this. We should be implementing, and over time, you know, we can see whether we have filled in all the gaps and whether we can remove some of those controls. But yeah, it certainly in this investigation, you know, when it came back that some of these controls weren't being implemented because the outbreak was done and things were getting easier, it's kind of like, well, you've missed the whole point. We had to prevent, because if you don't put these controls in place, you're not able to effectively prevent and or respond to the next outbreak that occurs. So we failed to learn anything through, you know, what we've been through.
So just I just wanted to, there's no more questions in the chat box. So just I noticed when you talked about the process, the last step was report, and I was thinking, well, you know, could there be another one, review? So you report, like, what about a review going back and looking at the effectiveness of controls? That was just something that triggered when I saw that.
That is actually part of the recommendation and developing corrective action piece. So we're going to develop these controls, we're going to put them in place, and over time we're going to have key points when we come back and we check the effectiveness. So we can do a residual risk assessment and say, yeah, you know, the current risk is X. If we put these controls in place, we believe we will reduce the risk to Y, and we're okay with that as a business. But then in the long term, we usually have stopgaps where it's okay, within an X period, we're going to come back and check, you know, we didn't have a repeat. Was it because the controls are working, right? We're going to audit them, or is it, you know, again, luck that got us to this point? So that is part of the recommendations, Kevin, is to ensure that we continuously check and ensure that those controls are in place, they are current, they are working, and they are being effective, not just today and tomorrow, but they're being effective long term. You know, one of the biggest issues we see is around management of change. For example, you make a design change in one place or one part of your business, and then 3 years later, we make a change upstream, and we don't actually look at what is the influence of that change on everything downstream in that process. And this is the exact same thing. If we make changes within our business, how does that influence the other controls that we have in place? Are they still effective?
Thanks. The second thought I had was, how do you address safety? How do you address culture? And I don't know, I was talking earlier on with Matthew Oliver about this, and he might want to chime in if he doesn't mind. But I'm just thinking, how would you address culture?
Culture is a difficult one to address because often it comes down to people say, well, we have a feeling. This is the feeling we get. We don't feel like management are invested, or, you know, managers don't do what they say they're going to do. From an investigation perspective, it has to be clear cut. There has to be physical evidence to support that. And I'll often, when I do case studies with groups in training, they'll come back as one of their key findings as an organizational factor is that the organizational culture is lacking. And I say to them, okay, well, what does that mean? That is so broad. That is such a big concept. And if you've made that as a contributing factor, you're now forced to address it with a recommendation. So tell me, Kevin, how do you address poor organizational culture? It's far too broad. You can't, because there's nothing specific that you're looking at. So through this process, we have a code organizational culture that you can apply to a contributing factor. For example, let's take the COVID example I looked at. We could say that, you know, the company has a masking policy. They have physical distancing. They have single entry and exit ways. You know, they have all these things in place, but nobody enforces them. And over time, it's kind of become, you said the word earlier, we've normalized deviance because it's just become the accepted practice. No one does it, so no one's going to do it. So whatever, we'll just continue going. That can be classified as organizational culture because we can address that. We can go back and see that over time there has been non-compliance to multiple policies, multiple standards, incorrect tool use, and it's been accepted. It's never been addressed by the business, although they are fully aware that it's occurring. So those would be how we would capture the cultural piece in an investigation, so that you can go back and you can actually address and pinpoint where those cultural issues exist.
I'm wondering, just thinking out loud here, you know, whether the lack of, upper management commitment could get worked on. And I know, from my experience, there are big companies that have actually had, they used to get DuPont to go in, and they used to coach the leaders to how to be good, to commit to, and improve the safety culture. Maybe that could happen. So there's another chat in the box here with measles. It's from Cheryl to everyone. With measles, Cheryl Rook it is, I think. With measles and H5N1 lingering in the background, would you change anything in your system to account for more highly infectious or more deadly viruses? Anybody else would like to chime in on that? Because that's kind of an interesting question.
I'll chime in from an ICAM perspective. This is the perfect opportunity to use ICAM as a risk management tool versus an incident investigation tool. I would bring up that ICAM chart where you have your defenses, your actions, your conditions, and your organizational factors. And I would look at my business and I'd say, right, if we had a smallpox outbreak, what controls do we currently have in place and what controls are missing? What don't we have that we should? Then I would look at the actions of the individuals and how those influence risk levels, right? Do we have the correct behaviors, understanding, training, etc.? Then I would look at the conditions and say, right, from an environment and a task perspective, in our industry, in our organization, what are the conditions that we need to promote to ensure that we have the right behaviors, right? So that we have the right resources, equipment, experience. And then that would drive me to those organizational factors, right? Do we have the policies, the standards, the resources, the culture to support this? And use it proactively. You'll be surprised at the benefit you can get from that.
Thanks, Mary Jane. I see we've got about 8 minutes left, and I really would like, if you wouldn't mind, Matthew to just to show himself. And I'm sure there's lots of things that are going on in your head, Matthew, having presented in the past too about failure. Have you got any thoughts you'd like to share with the group, if you don't mind?
I always have lots of thoughts. Thanks, Mary Jane. That was fascinating. I've been aware of ICAM from my time as a forensic investigator, but I've never actually seen it applied or used it. So thank you very much for the overview and your awesome answers. I guess the only sort of general comment I have is that the thing that's really powerful about these approaches like ICAM is that they draw the net really wide, and we still have, I still see it today in the industry in Canada, and I'm just next door in Alberta, Mary Jane. The tendency to say we've had a deviation that's caused an incident or an accident, there's been property loss or injury that's resulted from it, and the first thing we're going to do is punish the people who were involved, because if they had done their job properly, the valve wouldn't have blown, the thing wouldn't have fallen off. And that, I think that's one of the lessons I always try to pass on to people talking about incident investigation, is that you really got to get out of the blame game of trying to focus on the people who were involved. I mean, sometimes, as Mary Jane pointed out, if somebody's being negligent deliberately, that's a different issue. But most workers, just like most pilots, don't start their shift thinking, I'm going to kill somebody today. And that attitude, the blame attitude, is still very, very prevalent throughout all industries, healthcare included, I think, where the number of times I've seen in the last couple of years where we've had high levels of transmission in the facility, the cause is failure to comply with IPAC procedures. So if staff would just wash their hands properly, we wouldn't have the high transmission. And it's just such a shallow surface analysis, and it pushes all the blame off on the workers. So thanks for showing how ICAM steers us around that, Mary Jane.
Thanks,
No problem.
Matthew.
Thanks for the
really appreciate your thoughts there and just chiming in. I was also hoping, to have Lisa Brossu share her thoughts with everyone as well. She has a wealth of experience in this area from an occupational hygiene perspective. I don't know if you have any kind of thoughts going on in your head, Lisa, that you'd like to share with the group, or any questions, if you don't mind.
She might be gone. But Lawrence did volunteer.
Okay, Lawrence, over to you then, if Lisa's gone. Lawrence Virtue. Are you there, Lawrence?
Hi, Kevin. Mary Jane, thank you very much for the presentation. What I wanted to share is that I was a COVID compliance coordinator in the movie industry over the course of 5 months, approximately 500 workers per week over the course of 5 months. And through a predetermined prevention program, we had 0 COVID infections during that period of time. And I came out of that with the thought that the idea that COVID and diseases like COVID are preventable. And our experience was 100%. There was a prevention program put into place, and it was what we call a layered approach. We don't have time to go through the details of it, but what I want to say is that the workforce itself bought into the program 100%. And that, in addition to management commitment, is the fundamental reason we didn't have any infections. To give you one example, and one example only, I went up to the leader of the truck drivers one day and I said, "Hey, where's Joe?" And he said, "Oh, Joe, he didn't want to go with the program." He said, "We all have," the leader of the truck drivers, a Teamster, unionized, said, "We all have our theories about COVID. We all have our conspiracies. We have this, we have that, and ideas, but we want to stay at work, and we've got a good program here." So Joe didn't want to stay with the program. And we put the pressure on Joe to please disappear. And that's what happened. The workforce was extremely disciplined around the program that was put into place. They understood why. And after 5 months, we had a production that went up on time, on budget, with nobody getting sick. And I found that to be, in addition to management commitment and the program itself, the layered approach, to be the critical factor, the discipline of the workers. That's my contribution for today. Thanks, Ken.
Thanks, Lawrence, for sharing that with us. So we're kind of almost to a close, and I noticed, Matthew just put, in the chat box, if the risk is much greater, from more even highly transmissible disease, then that should prompt, a revised hazard assessment mitigation process. And Trevor Fish even kind of threw in, what about, add tuberculosis to that list as well. And we do hear that there are the occasional outbreaks of TB once in a while. So, I don't really have anything else to add to that. We've got 1 minute to go. Did you have anything, final comments, Val, before Mary Jane isn't with us anymore? I just really want to thank you to Mary Jane for volunteering your time, and it's such a fabulous process that you've shared with me. Hopefully people will be able to take what they've learned. So over to you, Val. Did you have anything else to say? Yeah.
I'm just texting with Tony because he has to go, so that's okay. I'm telling him that's okay. We can a couple things. One of them was Trevor did have his camera on, so he may have wanted to add something. I don't want to truncate that opportunity if he still is here and wanted to say more. I did have a question too for Matt. I guess because I do follow you on Twitter, and the stuff that's going on with these aviation incidents is alarming, but I'm also wondering about the frequency, the increased frequency potentially post-COVID. well, anyways, post-COVID infection, we know COVID's not over, but I'm just wondering from an incident investigation perspective, how do you apply this ICAM to, I guess, if there's a series of incidents happening in a workplace where you think that there's a level of cognitive change or something like that, how do we pick that up and I guess recognize it and then try and I guess prevent it? I mean, obviously we want to prevent the disease, but I don't know if you've given it any thought, Matt, in terms of how would you do an incident investigation like that? And then Trevor definitely will include you before we close off.
I'd certainly defer the ICAM part of that question to Mary Jane, because that's not a methodology I'm familiar with. But, you know, just like any complex failure scenario, that cognition would be one of the things that would come up. And in aviation accidents, very, very typical to look at the human factors and information processing related to that. And certainly in a few of the incidents that I've looked at as close as you can with public information, there's definitely communication, cognitive processing issues behind that. What might be causing them? It seems suspicious when there's a large uptick in incidents from the baseline that there's something else new that's going on. But the only thing I'd say generally is, you know, the aviation industry has been under a lot of stress the last few years, really cutting resources, expecting more out of staff. And even though, for example, aircrew have duty limits and that, my suspicion is the system is being stressed in a lot of ways right now. So this may be, as it almost always is in complex failures, the COVID cognitive impacts that we suspect are probably one of a list of factors that are combining together to lead to the failures or near failures.
Mary Jane, did you want to answer about it, just cognitive, I guess, in general? Is that ever something that gets into?
Yep. Absolutely. We address the cognitive factors, the human factors as part of the task and environmental conditions, so the conditions that influence performance. So looking at, you know, why did somebody do what they did? Well, it's often related to mental stress, mental fatigue, distraction in the workplace, the amount of information that's being given at any given time, how they process all of that information. So yes, that is absolutely captured through the process. I'm certainly not a human factors expert, but the process does allow for that. But we would certainly bring an expert in that area in if it was something we needed to address.
Mm-hmm. Great, thanks. Go ahead, Trevor.
Hello, can you hear me okay?
Yeah.
I just had a quick follow-up question. I'm occupational hygienist for Ministry of Labor. The core of our investigations has always been to talk to the affected workers and anybody involved in the incident, whether it's occupational illness, critical injury, fatality. I'm assuming safety-wise does the same thing.
Yes, absolutely. Every person directly involved and people indirectly involved who can provide additional information would always be part of that process.
Okay, thanks.
Thanks,
Sure.
Trevor.
Oh, I have one quick question for you, Trevor, because since I guess, because I'm, of course, as everyone here, probably very familiar with the critical injury obligations of reporting an injury and investigating an injury and actually documenting that and having it available, if not sharing it with the ministry. But how does that, are there any parallels, or where can we find a parallel for occupational illness and disease? And is there one in the legislation for committees to know about, or what would ever trigger an investigation of an occupational illness or disease, I guess, from a regulation perspective?
I believe it was in the latter sections of the Ontario Health and Safety Act about reporting requirements.
Mm-hmm.
There is a list, it's not comprehensive, of what would initiate a report. Also keep in mind the first 6 months of COVID, March 2020 up until I believe the end of August, WSIB was not accepting occupational illness reports for COVID. You'd have to ask WSIB about that, but kind of strange. I know there are reporting requirements. Influenza, gastro, obviously tuberculosis and the like. Form 7, Form 8 from WSIB. Worker made the employer aware of something that they thought affected or was a cause of the workplace. And it goes to the Ministry of Labor and or WSIB if there's a Form 7, Form 8 file. But also be aware of previous comments about respiratory protection over masks. My reference in the comments, Ministry of Health Directives 3 and 5, right? If you're all familiar with them, I assume you are. I'm not sure if they've been revoked or not, that any healthcare professional could, on their own risk assessment, determine that they required respiratory protection and ask for it from the employer.
Okay. I mean, you know, we still hear stories of, you know, people going to hospitals and being told to take off their own N95 and put on a surgical mask.
You're differentiating between workers and
Public
patients and the general public, though.
Mm. But I think even I think I've even heard that staff have gone in with their own N95s and been told. But I mean, that's just hearsay, right? But I'm just
Yeah, that's sometimes it's an issue between the employer and employee as well.
Thanks. I'll turn it over to you to close off, Kevin.
Yeah, I just really want to thank everybody for attending. We're down to 44. We're like 6 minutes over. And a huge thanks to you, Mary Jane. And, you know, just to take the time out and share this great knowledge with us, and hopefully it'll translate into some meaningful follow-up out there in different workplaces. And yeah, just really want to thank you so much for your time.
Thank you, Kevin, and to everybody else who's here. Thank you for taking the time to join us.
Okay, thanks everyone.
Yeah, thanks. Have a good weekend. We'll see you next time. We don't have it scheduled yet, but as I said in the chat, it'll be on our website in a few weeks probably. And thanks again, Mary Jane and Matt and Trevor and Vicky and everybody else who contributed. Bye-bye. Yeah.